Let's learn patho. The topic we are going to study in this video is benign prostatic hyperplasia, that is BPH. So what happens in BPH is there is androgen dependent proliferation of glands as well as the stroma of the prostate, which leads to nodular hyperplasia of the prostate. And the main androgen involved in BPH is dihydrotestosterone, that is DHT. BPH commonly affects men who are older than 50 years of age, and it is not considered as a pre-malignant lesion. That means it does not act as a precursor for the development of prostatic cancer. Coming to etiopathogenesis of BPH. So as we already discussed, the main androgen involved in pathogenesis of BPH is dihydrotestosterone. Now let's understand how this dihydrotestosterone is synthesized. So what happens in prostate? The testosterone is converted into dihydrotestosterone with the help of 5-alpha reductase type 2 enzyme, which is expressed in the stromal cells. Remember, these 5-alpha reductase type 2 enzymes are not expressed in the epithelial cells. So epithelial cells cannot convert the testosterone into dihydrotestosterone. So whatever dihydrotestosterone is produced in the stromal cells, they will diffuse and they will enter into the epithelial cells also. And in the stromal cells and the epithelial cells, there will be presence of androgen receptors. So this dihydrotestosterone will bind with the androgen receptors, and as a result of binding of dihydrotestosterone and androgen receptor, there will be transcription of the genes which are involved in the synthesis of growth factors. So there will be synthesis of a lot of growth factors by the stromal and the epithelial cells, and these growth factors which are synthesized here will in turn act on the receptors which are expressed by stromal cells and epithelial cells, leading to their proliferation and prostatic enlargement. Apart from the prostatic production of dihydrotestosterone, the DHT can also be produced at extraprostatic sites like skin and liver, as these sites express 5-alpha reductase type 1 enzyme. And the dihydrotestosterone produced at the extraprostatic sites will reach the prostate gland with the help of blood. So apart from testosterone and dihydrotestosterone, there is some role of estrogen in pathogenesis of BPH. So what happens normally, dihydrotestosterone acts on the stromal cells and it leads to production of growth factors. So the growth factors can be grouped into two groups. There are keratinocyte growth factors, epidermal growth factors, and insulin-like growth factors, which are responsible for epithelial cell proliferation. And then there are other group of growth factors which includes TGF-beta, which is responsible for epithelial cell death. So in a normal prostate gland, there is a balance between epithelial cell proliferation and epithelial cell death. But what happens in BPH is the estrogen will act on the epithelial cells and it will stimulate the epithelial cell proliferation and it will inhibit the epithelial cell death. So in this way, this estrogen is responsible for tipping the balance towards epithelial cell proliferation, leading to prostate hyperplasia. So after etiopathogenesis, now let's discuss about the morphological features which are seen in BPH. So starting with the gross features, what happens in BPH is there will be increase in size as well as the weight of the prostate. Now weight of the prostate increases 3 to 5 fold in case of BPH. Like normally weight is around 20 gram, and in BPH it increases to 60 to 100 gram. Apart from that, in the cut section, you can see hyperplastic nodules, which are mainly present in the transition zone and the periurethral zone of prostate. These hyperplastic nodules will basically encroach the urethra and they will compress it into a slit-like orifice. So as you can see in this diagram, here this is normal prostate gland showing a normal urethra, and in case of BPH, you can see hyperplastic nodules which are present in the periurethral and transition zone are compressing the urethra into a slit-like orifice. Apart from that, the color and the consistency of hyperplastic nodule depends upon what is the cellular content of the nodule. For example, if the nodule is predominantly stromal, it will appear pale grey and firm, while if it is predominantly glandular, then the nodule will appear yellowish pink and soft, and there will be exude of milky white prostatic fluid in the hyperplastic nodule. So you can see in this diagram, this is a cut section of a prostate in case of BPH. Here the urethral orifice is showing a slit-like appearance and it is due to basically the compression by the hyperplastic nodules in the transition zone and the periurethral zone. Now coming to the microscopic features. In the microscopy, you will see both glandular as well as stromal hyperplasia in case of BPH. You can see increased number of cystically dilated glands which are lined by two layers of cells, outer cuboidal basal layer and inner columnar secretory layer of cells. Apart from that, there are at some places the glands will show some infoldings leading to formation of papillary architecture, and in the lumen of glands you can see eosinophilic corpora amylacia. So talking about the microscopic features, here you can see cystically dilated glands having two layer of cells, corpora amylacia, and in between the glands you can see spindle shaped stromal cells which are also showing hyperplasia. So this diagram is showing a microscopic view of a whole mount of prostate. You can see the urethral orifice is compressed into a slit like opening due to the hyperplastic nodules present on both sides of urethra. And this diagram is showing the high power view of a single hyperplastic nodule. Here you can see corpora amylacia in the center, and the glands are lined by two layer of cells, and at some places the gland is showing infolding leading to formation of papillae. After microscopic features, let's discuss about clinical features. So basically what happens in BPH is there is lower urinary tract obstruction. And if there will be lower urinary tract obstruction, the patient will feel difficulty in starting and stopping the urinary stream. As a result of which, there will be increased frequency of micturition and especially increased frequency during night, which is known as nocturia. There will be retention of urine as impetting of bladder is not happening. And as a result of this urinary retention, there will be recurrent urinary tract infections. Dysuria, that is painful micturition, will be seen. The urinary retention will also result in bladder distension and hypertrophy, and there will be overflow dribbling also present. Now coming to the treatment part, so mild and symptomatic cases of BPH are managed medically with the help of alpha-adrenergic blockers and 5-alpha reductase inhibitors. So alpha-adrenergic blockers include tamsulosin and silodosin like drugs, which basically decrease the tone of prostatic smooth muscles, leading to easy passage of urine. And the 5-alpha reductase inhibitors like finasteride and dutasteride, basically they reduce the synthesis of dihydrotestosterone, leading to shrinkage of the prostate. Apart from medical management, the severe cases or the cases which are non-responsive to medical management are treated with the help of TURP, which is transurethral resection of prostate, HIFU, that is high intensity focused ultrasound, and laser therapy, etc. So this is all about BPH. Thank you for watching.